Hi everyone, my name is Sabrina DaSilva, and I am a second-year medical student at the University of Pennsylvania. Today, I'm going to present an update on CAR T-cell therapy for glioblastoma. Glioblastoma in the past has been very difficult to treat, but there's great excitement with 3 recent publications using CAR T-cell therapy. So today, we're going to do a deep dive so that we can understand how it works and what the different approaches are. Glioblastoma is one of the most aggressive tumor types and can be fatal. The current standard of care for glioblastoma includes maximum safe surgical resection, followed by radiotherapy, chemotherapy, and with or without tumor treating fields. With these therapies, we're aiming for long-term survival, which is a minority of patients. Unfortunately, 90% of cases recur. Clinical trial participation is often encouraged, and includes options like biologic therapy, immunotherapy, and targeted therapy. We're hopeful that these vaccines will produce more long-term survivors. Glioblastoma presents unique treatment challenges due to drug delivery in the setting of vascular remodeling, localization of tumors in the eloquent brain, neurotoxicity and other side effects, and resistance to conventional therapy. Fortunately, many research groups are working to develop novel therapeutics for glioblastoma, and one promising area of research lies in CAR T-cell therapy. CAR T-cell therapy uses a patient's own immune system to fight cancer by reprogramming their T-cells to recognize specific tumor antigens. CAR T-cell therapy has been very effective in liquid tumors like leukemia, lymphoma, and multiple myeloma, and is FDA approved for those indications. However, solid tumors have been difficult to target, and glioblastoma has been particularly challenging due to the immune privilege of the brain, the immunosuppressive tumor microenvironment, the hypoxic tumor environment, T-cell exhaustion, and tumor heterogeneity. However, in recent months, 3 groups have shown that changing the route of delivery may help us figure out how to better target glioblastomas using CAR T-cells. These updates on CAR T-cell therapy in recurrent glioblastoma will be reviewed today. So today I'm going to be talking about these 3 different papers, and for each paper, I will be discussing the methods, design, efficacy, toxicity, and conclusions. The first updates I'll discuss today are coming from Dr. Stephen Bagley, Dr. Donald O'Rourke, and their team at the University of Pennsylvania. So far, they've recruited 6 patients with recurrent glioblastoma that is IDH wild type. They designed CAR T-cells that target both the epidermal growth factor receptor, or EGFR, and the interleukin-13 receptor subunit alpha 2, or IL-13R alpha 2. And they delivered these CAR T-cells via intrathecal injection through an intraventricular reservoir. In this study, they enrolled patients with glioblastoma recurrence, initiated manufacturing for CAR T-cells, during which they underwent surgical resection or debulking and Ommaya reservoir placement. Then, after the CAR T-cells were manufactured, they were administered intrathecally. Of note, patients 1 to 3 were treated with 10 million CAR T-cells, and patients 4 to 6 were treated with 25 million CAR T-cells. Brain MRIs were obtained 24 to 48 hours after CAR T-cell administration, as well as on day 28 and monthly thereafter. Here are representative MRI images from patient number 1. In all 6 patients, they observed reductions in enhancement and tumor size on brain MRI scans 24 to 48 hours after intraventricular CAR T-cell delivery. Additionally, partial tumor regression was maintained at day 28 and beyond in a subset of cases. CSF analysis showed CAR T-cell levels in the CSF after injection. CAR T-cells were also found in the peripheral blood, demonstrating communication between the CSF and peripheral blood compartments. Additionally, cytokine markers of T-cell activation all showed rapid increases in CSF after CAR T-cell injection, before subsiding to baseline levels in around 2 weeks. In this study, they did not observe any toxicities greater than grade 3. There was one patient who met criteria for dose-limiting toxicity, which improved with dexamethasone. Other early-onset neurotoxicities were effectively managed using dexamethasone and anti-interleukin-1 agents. In conclusion, they present the first in-human data to demonstrate the preliminary safety and bioactivity of their CAR T-cells that target EGFR and IL-13R-alpha-2 in recurrent glioblastoma. They also note that an encouraging early efficacy signal was detected and requires confirmation with additional patients and longer follow-up time. Lastly, neurotoxicity and other side effects were effectively managed with dexamethasone and anti-interleukin-1 treatment. The next updates I'll discuss are coming from Dr. Christine Brown and their team at City of Hope. In this study, 65 patients with recurrent, high-grade, multifocal glioma, with the majority being glioblastoma, were treated with CAR T-cells targeting IL-13R-alpha-2 and delivered either intratumorally, intraventricularly, or via both modalities. In this study, they enrolled patients with glioblastoma recurrence and initiated leukapheresis for CAR T-cell manufacturing. Then they proceeded with surgery and catheter placement, followed by PET and MRI imaging. Patients received 3 to 4 injections of CAR T-cells directly into the tumor or lateral ventricle or into both locations. Dose-limiting toxicity was monitored and was not reached. In this study, they divided their patients into 5 different arms based on CAR T-cell delivery route. For example, arms 1 and 2 were delivered intratumorally, arms 3 was delivered intraventricularly, and arms 4 and 5 were delivered intratumorally and intraventricularly. Also of note, they used 2 manufacturing platforms for the CAR T-cells that differed in T-cell subsets. Arms 1 through 4 used central memory T-cells, and Arm 5 used stem cell memory and central memory T-cells. For results, there is a statistically significant improved survival in the group Arm 5, which got both the intratumoral and the intraventricular injections of the CAR T-cells manufactured with the stem cell memory and central memory T-cells. They also noted that stable disease was attained in 29 out of 58 patients overall across all 5 arms. Then, when they developed a score for the infiltration of the active CD3 T-cells, they found a statistically significant infiltration of T-cells, which shows histologic activity in the tissue as well as radiographic responses. Furthermore, the tumors with the highest infiltration of CD3 positive T-cells were associated with improved overall survival. For toxicity, they did not observe any dose-limiting toxic effects. However, they did observe grade 3 and above toxicities in 35% of patients. Reassuringly, however, there were no toxicities above grade 3 in arms 1, 2, or 5. Toxicities were clinically managed by increasing systemic steroids and symptomatic management. In conclusion, their study overall achieved stable disease or better in 50% of their patients. They conclude that the combined intraventricular and intratumoral delivery of CAR T-cells showed the highest infiltration of active CD3 T-cells as well as the best survival. Additionally, they have demonstrated that repetitive local regional administration of their CAR T-cells targeting IL-13R-alpha-2 is feasible and safe with no dose-limiting toxicities. Finally, future directions include moving forward with Arm 5, which was the dual intratumoral and intraventricular delivery with the optimized CAR T-cell manufacturing process. This is also the arm that achieved a maximum feasible dose of 200 million CAR T-cells per infusion and displayed the best overall survival. The final updates I'll discuss today are coming from Dr. Brian Choi, Dr. Marcella Maus, and their group at Harvard. In this study, 3 patients with recurrent glioblastoma were treated with CAR T cells targeting both the wild-type EGFR and the EGFR variant 3 tumor-specific antigen through secretion of a T cell engaging antibody molecule, which they called TEAM. Their CAR T cell complex was delivered intraventricularly through an Ommaya reservoir. In this study, they ultimately designed a protocol where they enrolled patients with glioblastoma recurrence, initiated leukapheresis for CAR T cells, then they proceeded with a single surgery for concomitant cradiotomy, tissue sampling, and Ommaya reservoir placement. Then, after CAR T cells were manufactured, patients were admitted for intraventricular CAR T cell infusion through the Ommaya reservoir. This study presented results from 3 patients, but I'll be using representative results from patient 2. In all 3 patients, they showed radiologic evidence of rapid and dramatic tumor regression by day 2 after CAR T cell infusion. In patient 2, this regression was sustained at later time points, but the other 2 patients experienced eventual tumor progression. Additionally, CSF analysis showed a decrease in copy numbers of EGFR and EGFR v3 over time, remaining below detection in post-treatment samples. CSF samples were analyzed and showed the presence of CAR-positive and TEAM-positive T cells temporarily in the CSF sample after infusion, but their presence declined by week 4. Similar trends were also observed in the inflammatory cytokines present within the CSF after infusion. For toxicity, they had no dose-limiting toxic effects. They had no adverse events greater than grade 3. Of note, all 3 patients had fevers that peaked by day 2, and these were managed with anakinra. In conclusion, they observed rapid tumor regression within days of CAR T cell infusion. However, 2 of the 3 patients had eventual tumor progression, corresponding with the limited persistence of their CAR T cells in the weeks following infusion. Additionally, their CAR T cells showed promising safety profiles without severe adverse events or dose-limiting toxic effects. Finally, future directions include developing strategies to enhance the durability of their TEAM CAR T cells, perhaps through preconditioning with chemotherapy or through additional scheduled infusions. Now, let's summarize our key takeaways from the 3 papers we reviewed today. In summary, dual surface antigens can be targeted simultaneously by CAR T cells. It is feasible to deliver up to 100 million CAR T cells intratumorally, intraventricularly, or intrathecally. All trials observed early responses within 24 to 48 hours, likely due to tumor killing by T cells. CAR T must face several challenges: the limited accumulation and persistence of T cells in the CNS, T cell exhaustion, antigen loss, and local and systemic immunosuppression. The main conclusion overall is that changing the route of delivery could help determine methods to better target glioblastomas using CAR T cells. Future directions broadly include enhancing the presence, persistence, and potency of CAR T cell therapy. And with that, I would like to thank the entire Penn Neurosurgery department, especially Dr. Stephen Brem, who is the Neurosurgery Clerkship Site Director, as well as the Penn Brain Tumor Center neurosurgeons. During my rotation, I had the privilege to learn from many of these neurosurgeons in the OR or in teaching. I would also like to acknowledge the other neurosurgeons who I learned from during my rotation, as well as the fellows, chiefs, residents, and sub-Is who made my experience so wonderful. Here are all of my references. Finally, I enthusiastically encourage any feedback and correspondence. I've listed my email address and my Twitter handle on the screen, and I am more than happy to connect. Thank you very much.